Hey YouTube, welcome back to my channel. My name is Dr. Daniel Kaplan and my mission is to make psychology accessible to all. And I'm in the middle of a 30 for 30 videos in 30 days. And the topic that I am focused on is mental health and psychological disorders. So if you like what you have to hear, hit the like button, subscribe, click the notifications tab. Ignore my cat in the background. But in today's video, we're going to talk all about premenstrual dysphoric disorder, or PMDD. This is a new condition that was added to the DSM-5, which is the manual we use for assessment as well as diagnosis. And there was a lot of controversy around it. But without further ado, let's talk about the diagnosis. So premenstrual dysphoric disorder, also known as PMDD, has quite a few criteria that it has to be met. The first criterion is that in the majority of the monthly cycles within the last year, a person must have 5 symptoms of mood dysregulation and whatnot. Now, what we see is that there's something called a hazard zone. And the hazard zone is as follows. So in the final week leading up to the menstrual cycle, there is typically a dysregulation of mood, and it starts to recover in the first few days of the menstrual cycle when it starts to occur. And then in the middle of the month, this mood dysregulation is entirely absent. So if you can see my cursor, you're going to see the week leading up, PMDD, 21 through 28 days. The average monthly cycle, menstrual cycle, is about 28 days. That's why we use this model. Some women have a shorter cycle, some women have a longer cycle, but this is the average. So 21 through 28, that's the week leading up to the menstrual cycle. And then for the first few days, you're going to have the most mood dysregulation the week leading up to it. You're still going to have some mood dysregulation the first few days of the menstrual cycle. And then, like I said, in the middle, this mood dysregulation is fairly absent. Now, you have to track the menstrual cycle and your mood for 12 months, right? And you have to see more months than not. So we're going to say about 7 out of 12 at a minimum, you have at least 5 mood-based issues. Now, that would be the first criterion in order to get the diagnosis of PMDD. You also have to have at least one, if not more, of the following features: marked affective lability, so mood swings, emotion dysregulation, tearfulness, fear of rejection. You could have irritability or anger that's increased and manifest by interpersonal conflict. You could have depressed mood, feelings of hopelessness or self-deprecating thoughts, which is one of the features why we talk about it as a mood condition. You could also have anxiety or tension or other feelings of being keyed up. Sorry about that. So you could feel on edge, keyed up, whatnot. Now, notice it said 1 or more. The same thing with criterion C. You have to have 1 or more of the following features. And between criterion B and C, you have to have at least 5. So criterion C, it might cause difficulty with relationships, work, friends, school, your hobbies, your usual activities. It might result in difficulty concentrating, lethargy, eating changes, sleeping changes, feeling overwhelmed. And keep in mind, these are hallmark features as well of unipolar mood disorders, right? So major depressive disorder, if you go back to my video on that, you'll see that it was also there. And then, you could also have a physical symptoms such as swelling and breast tenderness, muscle pain, things like that. And number 7 on criterion C is fairly common even in the absence of PMDD. And that's why we need more than just one feature, right? So you need at least 5. And as I mentioned, it has to be most menstrual cycles in the past 12 months to get a diagnosis. I will say that you can give a provisional diagnosis before confirmation, but if you want an accurate diagnosis, you want to make sure that you have confirmation. So criterion D is that it causes significant distress, as we talked about. C is that it's not merely exacerbating some other mental health concerns, such as major depression, panic disorder, persistent depressive disorder, or even a personality disorder, right? So it can't be an exacerbation of another psychological condition. However, that doesn't mean that it can't occur with another disorder. So it's possible for a person to have multiple diagnoses. And in this case, if you meet the full criteria of each independently, you can have co-occurring diagnoses. Now, criterion F, again, we should have a confirmation-based process where we track very carefully at least 2 symptomatic cycles and ask for daily ratings. And this is going to allow us to make sure that our retrospective memory is not biasing things. And we'll talk about retrospective memory in a minute. And then, of course, there are a whole host of physical issues that could induce it, or medical issues, biological factors such as substance abuse, medication, hyperthyroidism, things like that could also induce it. So here is a logic tree, a flow chart to tell you how you would process it. So the first thing you're going to do is get a full psychiatric history, and then you're going to determine whether there is a primary mood or anxiety condition beyond the late or early phase of menstruation. And then if no, then it's easy, right? We can go down our symptoms. We have 5 symptoms with at least 1 affective, at least 1 behavioral cognitive. And then if we have fewer than 5 symptoms, then we call this premenstrual syndrome, which is a subclinical term for when all the criteria of PMDD are not met. And then for that, treatment would be optional. But if you have 5 or more symptoms, then you can get the provisional diagnosis of PMDD, as I mentioned, but you want to track at least 2 cycles for a more definitive confirmation. So that's the easy process. But remember, we said that it cannot just be a mere exacerbation of another condition. So if you have mood issues that go beyond the late stage of one's menstrual cycle or the early stage of one's menstrual cycle, then we have to go through another set of logic. So if you said, yes, I do have mood conditions, I do have anxiety beyond this period, then we have to ask ourselves, do the symptoms worsen during the premenstrual period? If the answer is no, then it has no relationship to PMDD whatsoever. If the answer is yes, then we at least have a premenstrual exacerbation, right? So then we have to determine whether the symptoms are persisting to a clinical level. And then if the premenstrual symptoms persist, then once again, because we need the confirmation, we're going to track the menstrual cycle at least two cycles to confirm the diagnosis. So you'll notice there is a pathway to determine whether there's PMDD with or without other psychological disorders being present. So what is the frequency of this condition? It's in a 1-year reporting rate, we have anywhere between 1.8 to 5.8% of menstruating women. Now, the reason why we want the 2-month daily tracking is we know that estimates are significantly inflated if they're based on retrospective reports or going backwards rather than the daily ratings. The onset of premenstrual dysphoric disorder can occur at any point after one starts to have their period or menstrual cycle. And if we were to look at the incidence of new cases in a 40-month period, it's about 2.5%, right smack in the middle. So it is possible that these rates are hovering in about 1 to 3%, maybe 5% at the most, but we know that there's some over-reporting. Now, in terms of race and ethnicity, there's no clear evidence that one race or ethnic group differs significantly from the next. And then in terms of treatment, we acknowledge that PMD is a serious and chronic condition, and it does need treatment, right? So it's not a subclinical issue. At this point, you have 5 or more features, you have dysregulation, problematic friendships or relationships. We need to treat it. So how do we treat it exactly, though? There are several approaches, some of which are stress management and diet. And then there are some that are more biologically driven in terms of medication. So typically the treatments, though, are designed to alleviate the severity of the condition. So how do we do it? So one thing is we want to increase protein and carbohydrates in our diet and reduce exposure to things like sugar, salt, caffeine, and alcohol. That's going to help reduce bloating. You're also going to want to increase exercise, work on stress management, and these are going to help you with some of the stress and mood dysregulation, vitamin supplements, anti-inflammatories, and then in terms of psychopharmacology, SSRIs, or your selective serotonin reuptake inhibitors, which are one of the more common antidepressant medications, can be prescribed. And if you want to even out the menstrual cycle and reduce the swings that are connected to estrogen and progesterone, we also have the concept of birth control pills. So that's really PMDD. As I said, it is new to the DSM-5. It was added after about 20 years of additional research and confirmation that this is a consistent pattern. It is not a culturally dependent pattern. So it needed to be added to the DSM. I will say before I finish up, though, if we look at the rates of PMDD, it also has, a message for us. There is this over pathologizing women while they're on their menstrual cycle. So, oh, she must be on her period. Phrases like this can be quite offensive. And if you look at the epidemiology, it is very infrequent that a person meets the criteria for PMDD. So linking one's mood in a pathological way to the menstrual cycle is, it's a form of sexism. So we have to be careful with that. So that was my final thought on that. If you like this video, hit the like button, subscribe, click the notifications tab, and in the comments, if there's something that you want me to do a video on, please feel free. I'm open to that, and I look forward to your comments. Take care, everybody.